Bipolar disorder is often described as simply having extreme mood swings, but that description misses a lot of what bipolar disorder actually is. Bipolar disorder are mental health conditions involving significant changes in mood, energy, activity, thinking, and functioning. And there are important differences between bipolar 1 and bipolar 2 disorders. In this video, we're going to look at the symptoms of bipolar disorder, the difference between mania and hypomania, and how bipolar 1 and bipolar 2 are diagnosed, and what causes bipolar disorder, risk factors and triggers, and the evidence-based treatments that can help. We'll also talk about what living successfully with bipolar disorder can actually look like. The goal isn't to label ordinary changes in mood as a disorder, it's to understand when changes in mood and energy becomes clinically significant and what can be done about them. What is bipolar disorder? Bipolar disorder involves episodes in which a person's mood and level of activation change significantly from their usual baseline. These changes can affect mood, energy, activity, thinking, sleep, judgment, and functioning. The two terms you'll hear throughout this presentation are mania and hypomania. Mania is a more severe, elevated, or irritable state. Hypomania has many of the same features, but is less severe. People with bipolar disorder can also experience major depressive episodes, which can involve persistent sadness, loss of interest, low energy, changes in sleep and appetite, difficulty concentrating, feelings of worthlessness, and sometimes thoughts of death or suicide. One of the most important concepts is that bipolar disorder isn't simply about feeling happy one day and sad the next. Most people experience changes in mood. That's perfectly normal. Bipolar disorder involves distinct mood episodes that represent a significant change from a person's usual functioning and meet specific clinical criteria. Bipolar 1 versus bipolar 2. This is one of the most important distinctions to understand. Bipolar 1 disorder is defined by the occurrence of at least one manic episode. A person with bipolar 1 may experience major depressive episodes, but a major depressive episode is not required to make the diagnosis. Bipolar 2 disorder is different. To meet criteria for bipolar 2 disorder, a person must have experienced at least one hypomanic episode and at least one major depressive episode, and there cannot be a history of a manic episode. So the difference isn't simply that bipolar 1 is severe and bipolar 2 is mild. In fact, bipolar 2 can involve substantial impairment, particularly because the major depressive episodes can be severe and persistent. Here's an example. Imagine two people who both experience periods of unusually high energy, decreased need for sleep, rapid speech, and increased activity. For one person, the episode becomes severe enough that their functioning deteriorates dramatically. They may become extremely impulsive, require hospitalization, or develop psychosis. That pattern could be consistent with mania and therefore bipolar 1. For another person, the elevated period is clearly different from their normal functioning but does not cause the marked impairment characteristic of mania. They may feel unusually productive and energized, but they later experience a major depressive episode. That pattern may better fit with bipolar 2 disorder. Understanding the distinction is essential for accurate diagnoses and treatment. What is a manic episode? Let's take a closer look at mania. A manic episode involves a distinct period of abnormally and persistently elevated, expansive, or irritable mood, along with increased energy or goal-directed activity. During mania, someone may need very little sleep, but still feel extremely energized. They might talk much faster than usual, have racing thoughts, become unusually confident, take on multiple projects, spend excessive amounts of money, become sexually impulsive, or make decisions without adequately considering the consequences. Here's a realistic example. Imagine someone who normally sleeps 7 or 8 hours a night. Over several nights, they begin sleeping only 2 or 3 hours, but they don't feel tired. Instead, they feel fantastic. And then they decide they're going to start 3 businesses, remodel their entire house, write a book, and launch several other projects, all at the same time. They're talking rapidly, jumping between ideas, spending thousands of dollars, and becoming increasingly difficult for family members to reason with. At first, some of this behavior might even look productive, but as the episode progresses, judgment becomes increasingly impaired. They may make financial decisions they wouldn't normally make, become involved in dangerous activities, experience severe conflict with other people, or lose touch with reality. In some cases, mania can involve psychosis, such as delusions or hallucinations. The defining issue is not simply that someone is energetic or happy. Mania represents a significant change from the baseline that causes marked impairment, hospitalization, or psychotic features. And because mania can dramatically affect judgment and behavior, it can have consequences that continue well after the episode ends. What is hypomania? Hypomania can look similar to mania, but there are important differences. Someone experiencing hypomania may have increased energy, decreased need for sleep, rapid speech, racing thoughts, increased confidence, increased goal-directed activity, or greater impulsivity. The difference is primarily severity and functional impact. Hypomania represents a clear change from a person's usual functioning, but it does not cause the marked impairment characteristic of mania. It also does not involve psychosis. This is important because hypomania can sometimes feel good. Someone might think, I feel more creative. I finally have the energy to get things done. I'm more confident than I've ever been. I'm sleeping less and I don't feel tired. And from the person's perspective, those changes may initially seem quite positive. But clinically, a significant change in mood, energy, sleep, or behavior still matters, even when the person enjoys the experience. For example, someone might suddenly become extremely productive, start several projects, socialize a lot more than usual, and function on very little sleep. Their family might recognize that they're behaving very differently, even though the person doesn't necessarily see anything wrong. It's also important to remember if psychosis occurs during an elevated episode, the episode is considered mania rather than hypomania. That's one reason careful assessment of the entire episode is so important. The depressive side of bipolar disorder. When people hear the term bipolar disorder, they often focus on mania or hypomania, but depression can be a major source of suffering and impairment. A major depressive episode can involve persistent sadness or emptiness, loss of interest or pleasure, fatigue, sleep changes, appetite or weight changes, difficulty concentrating, feelings of worthlessness or excessive guilt, and thoughts of death or suicide. For some people with bipolar disorder, depressive symptoms may occupy much more of their lives than elevated episodes. This is especially important in bipolar 2 disorder because major depressive episodes are part of the diagnoses. Imagine someone who spends several weeks barely able to get out of bed. They stop enjoying activities they normally love. They're exhausted, having difficulty concentrating at work, withdrawing from friends, and beginning to believe that they're a burden on everyone around them. That isn't simply being in a bad mood. It's a potentially serious depressive episode that deserves professional evaluation. And when someone experiences suicidal thoughts or feels unable to stay safe, that requires immediate attention. Bipolar depression can also be complicated because treatment decisions have to account for the person's history of mania or hypermania. This is one of the reasons accurate diagnosis matters so much. Understanding the pattern. One useful way to understand bipolar disorder is to look at how changes in mood, sleep, energy, and behavior can interact. Consider a person entering a manic or hypomanic episode. They begin to sleep less. Because they're sleeping less, their energy and behavior change. They become increasingly active, talkative, impulsive, or goal-directed. Those changes may lead to consequences, conflicts, financial problems, problems at work, relationship difficulties, or other stressful situations. Eventually, the person may move towards stabilization or into a depressive period. The cycle isn't necessarily identical for every person, and bipolar disorder doesn't mean that someone constantly cycles between mania and depression. Episodes can last for weeks or longer, and there can be periods of relative stable functioning between episodes. But sleep is particularly important. A person who is beginning to sleep significantly less than usual may be showing an early warning sign of mood elevation. That doesn't mean every night of poor sleep is the beginning of mania, but for someone with bipolar disorder, a consistent pattern of decreased need for sleep combined with increasing energy, activity, or impulsivity may deserve close attention. Recognizing these patterns early can create an opportunity to intervene before symptoms become more severe. So, what causes bipolar disorder? There isn't a single cause. A useful way to understand bipolar disorder is through the biopsychosocial model. Biologically, genetics play an important role. Bipolar disorder tends to run in families, although having a family member with bipolar disorder does not necessarily mean that someone will definitely develop it. Researchers also study differences in brain functioning and other biological processes that may contribute to vulnerability. Psychological factors can also influence how someone responds to stress, regulates emotion, interprets experiences, and manages changes in mood and behavior. And then there are social and environmental factors. Chronic stress, major life changes, disrupted sleep, and substance use can all interact with an underlying vulnerability. For example, someone may have a biological predisposition toward bipolar disorder, then they experience prolonged stress and several weeks of severely disrupted sleep. That doesn't mean the stress caused bipolar disorder. Instead, those factors may contribute to the emergence or worsening of symptoms in someone who is already vulnerable. This is why bipolar disorder is best understood as a complex interaction of biological, psychological, and environmental influences rather than the result of one specific cause. What can increase risk? It's important to distinguish risk factors from direct causes. Having a risk factor does not mean someone will develop bipolar disorder or experience an episode. Family history is one important risk factor. Other factors can increase vulnerability to destabilization, particularly in someone who already has bipolar disorder. These can include significant sleep deprivation, major stress, substance use, medication changes, and disrupted routine. For example, imagine someone with well managed bipolar disorder who has maintained a regular sleep schedule for months. They begin working overnight shifts, sleeping only a few hours during the day, using stimulants to stay awake, and skipping meals. That does not guarantee an episode will occur, but it does create conditions that may make mood stability more difficult. Similarly, suddenly stopping or changing psychiatric medication without medical guidance can increase the risk of destabilization for some people. The key point is that risk factors do not cause every episode. Instead, they increase vulnerability or contribute to destabilization. Learning individual triggers and early warning signs can become an important part of long-term management. How is bipolar disorder diagnosed? Bipolar disorder isn't diagnosed simply because someone reports feeling very happy, very energetic, or very depressed. Diagnosis requires looking at the person's history over time. A clinician may conduct a detailed clinical interview and ask about previous mood episodes, changes in sleep, energy, behavior, impulsivity, depression, functioning, and relationships. They may ask important questions that the person hasn't considered important. For example, have you ever gone several days with very little sleep and still felt energized? Have there been periods where you were unusually talkative or active? Have you made unusually risky financial or sexual decisions? Have other people told you that you seemed very different from yourself? The clinician also needs to determine how long symptoms last and how severe they were. Substance use and medical conditions also have to be considered because certain substances, medications, and medical conditions can produce symptoms that resemble mood episodes. The DSM-5-TR provides specific diagnostic criteria for manic, hypomanic, and major depressive episodes. This is why distinguishing between mania and hypomania and depression is so important. A single appointment captures one moment in time. Bipolar disorder requires understanding the person's patterns across time. Bipolar disorder is very treatable, but treatment is usually an ongoing process rather than a one-time intervention. Treatment often involves several components. The first is medication management. Mood stabilizers and other medications may be used depending on the person's diagnoses, current symptoms, medical history, and treatment needs. Medication decisions should be individualized and managed with an appropriate medical professional. Psychotherapy is another important component. Cognitive behavioral therapy, or CBT, can help people identify patterns that contribute to problems and develop strategies for managing symptoms. Psychoeducation helps people understand their diagnoses, recognize warning signs, and become active participants in their treatment. Interpersonal and social rhythm approaches can focus on maintaining regular routines, sleep patterns, and interpersonal stability. Other evidence-based approaches may also be incorporated depending on the person's needs. And then there are daily stability strategies. Consistent sleep, regular routines, monitoring mood changes, avoiding substances that can destabilize mood, and maintaining a support system can all be important. Treatment is not about forcing someone to become a completely different person. The goal is to reduce episodes, improve function, increase stability, and help the person build a life that is meaningful to them. Living successfully with bipolar disorder often involves learning your own patterns. One person might notice that their earliest warning sign is sleeping less. Another person might notice that they're suddenly talking much faster. Someone else might recognize that they're becoming unusually ambitious or spending more money, starting multiple projects, or becoming increasingly irritable. Let's take an example. Someone notices that they've gone from needing 7 or 8 hours of sleep to only needing 3 or 4. They're also talking faster, making more plans, and feeling unusually confident. Instead of thinking, I'm just having a productive week, they recognize this as a potential warning sign. They contact their treatment provider, talk with their support system, protect their sleep schedule, and begin following well-established episode response plan. That doesn't guarantee an episode won't develop, but early intervention may help reduce the severity or consequences. This is why stability isn't just about medications. It can also involve sleep, routine, self-monitoring, treatment adherence, support, and knowing your early warning signs. Over time, these strategies can help people become much more informed about their own mental health. Bipolar disorder, myth versus reality. Let's go ahead and clear up a few common myths about bipolar disorder. Myth number 1. Bipolar disorder is just mood swings. In reality, bipolar disorder involves clinically significant mood episodes that meet specific criteria. Everyone has mood changes. Bipolar episodes are different in their severity, duration, and impact. Myth number 2. Bipolar disorder isn't serious. In reality, bipolar 2 does not involve full mania, but the depressive episodes can be severe and disabling. Myth number 3. People with bipolar disorder can't live stable lives. In reality, many people with bipolar disorder achieve significant stability and maintain relationships, careers, families, and meaningful lives. Finally, mania just means being really happy. That's not accurate. Mania can involve irritability rather than happiness. It can involve impaired judgment, impulsivity, severe disruptions in functioning, and sometimes even psychosis. Understanding these distinctions helps reduce stigma and makes it easier to recognize when someone may need professional support. How can you help? If someone you care about has bipolar disorder, your role is not to become their therapist or trying to control their symptoms. Your role is to provide appropriate support. This might mean listening without judgment, encouraging professional treatment, help support healthy routines, or noticing significant changes in behavior. For example, if someone who normally sleeps 8 hours suddenly begins sleeping 3 or 4, talking much faster, spending excessively, and becoming increasingly impulsive, you might say, Hey, I've noticed that you're sleeping a lot less and seem to have a lot more energy than usual. How are you doing? That's very different from saying, You're acting crazy. The goal is to communicate concern without shaming the person. During severe episodes, arguing about every belief or behavior may not be productive. And when there are serious safety concerns, such as suicidal thoughts, severe impairment, psychosis, or behavior that places a person or others in danger, those concerns should be taken seriously, and appropriate professional or emergency support should be sought out. Support matters, but the person and their treatment team remain responsible for managing the disorder. Let's bring everything together. Bipolar 1 disorder involves at least one manic episode. Bipolar 2 disorder involves hypomania and major depressive episodes without a history of mania. Bipolar disorder is more than just ordinary mood swings. It involves clinically significant changes in mood, energy, activity, thinking, and functioning. We also looked at how biological, psychological, and social factors can contribute to vulnerability and how sleep disruptions, stress, substance use, medication changes, and disrupted routines can contribute to destabilization. Most importantly, bipolar disorder is treatable. Treatment may include medication management, psychotherapy, psychoeducation, routine and sleep stabilization, mood monitoring, and a strong support system. Successful management doesn't mean that someone has to live a small or restricted life. It can mean learning your patterns, recognizing warning signs, getting appropriate treatment, and developing strategies that help you remain stable. If you or someone you care about is experiencing symptoms of bipolar disorder, consider talking with a qualified mental health professional or medical professional for an appropriate evaluation. I've also created a free bipolar disorder educational handout that goes along with this presentation. You can download it through my Shopify store. And follow the Quiet Mind Counseling for more educational videos covering mental health diagnoses, coping skills, psychology, and evidence-based treatment strategies. If you're living with bipolar disorder, remember, your diagnosis is something you manage. It's not the entirety of who you are. Stability is possible. Meaningful relationships are possible. A fulfilling life is possible. I'm Dr. Daniel with The Quiet Mind. Thanks for watching.